Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Hello and good afternoon, everyone. Welcome to the next AIIMS NAMS Navigate Medical CME program. So this time we are going to cover a very important topic, that is allergic bronchopulmonary aspergillosis, which is commonly known as ABPA. So in Indian community, since we have a high burden of tuberculosis and other respiratory disorders like asthma, COPD, so comorbidity or like the presence of both the disorders often lead to high comorbidity. Often ABPA is misdiagnosed. So there are a lot of challenges to diagnose ABPA and further the treatment of ABPA. So today we have with us our eminent speaker for today, Professor Ritesh Agarwal sir. So I welcome sir and I welcome all the delegates to the next and the new medical CME program. So with this, I request Mr. Raviji to play for the message from the President, National Academy of Medical Sciences.
My dear young colleagues, faculty and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you, Raviji. So now we would listen to the message from Director, All India Institute of Medical Sciences, Professor M. Srinivas. So over to you. Yeah, please. Thank you.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Been NAMS has been conducting this CME program since 2021. We all have been into this program since the beginning, since its inception. Uh, all the lectures are recorded and simultaneously they are also live streamed on YouTube. Currently, as far as I can see, 73 participants are there on YouTube, and around 26 participants are there on Zoom. So this program is live telecasted on YouTube, and then later the video is saved and preserved on YouTube. Also, we display the link of this particular lecture on our NAMS website. So anyone who couldn't attend this lecture due to their duty or other engagements, they can just visit our website and they can watch the lecture. If they have any doubt, they can mail us and we coordinate with you to resolve their queries. So it's our honor and privilege to have Professor Ritesh Agarwal sir with us for this important lecture. Sir is Professor of Pulmonary Medicine at PGIMER Chandigarh. Sir has numerous publications and chapters in his name, and the single word that I would like to mention is that his H index is 86. That's very huge, and that shows his research excellence. Sir also been awarded various prestigious award, including ICMR Kamal Sadbir Award and Shanti Swaroop Bhatnagar Award and numerous others. Sir is also a fellow of very prestigious associations of medical sciences worldwide. With this brief introduction and without wasting much time, I request and I hand over this dice to Professor Ritesh Agarwal sir, and we all are eager to listen to his pearls of wisdom. So over to you, sir.
Thank you, Dr. Jangra. I hope I am audible.
Yes, sir. You are very well audible, sir.
Thank you for confirming that. So today, first of all, good afternoon, everyone. This is the problem of an online platform. You forget that somebody is listening to you at the other end. You really are in a virtual world now. So good afternoon, everyone. Today we'll be diving deep into allergic bronchopulmonary aspergillosis, or ABPA, a condition that exemplifies how our understanding of respiratory medicine has continued to evolve. So we'll be discussing the recent updates in the diagnosis and treatment of ABPA. This presentation is heavily influenced by the 2024 International Society for Human and Animal Mycology ABPA Working Group Guidelines, which is a collaborative effort from 39 international experts across 13 countries. And I believe this guideline would significantly impact how we diagnose and treat ABPA globally. So what is ABPA? ABPA is a complex disorder caused by immune responses mounted against Aspergillus species, colonizing the tracheobronchial tree of patients with asthma and cystic fibrosis. On the other hand, ABPM, or allergic bronchopulmonary mycosis, is an ABPA-like syndrome caused by fungi other than Aspergillus species. So the interest in ABPA stems from the fact that the condition responds remarkably to treatment with steroids or antifungal triazoles. In fact, early detection and treatment can prevent the progression and sometimes the onset of bronchiectasis. Indeed, it is considered a treatable trait in bronchiectasis. For instance, most patients with ABPA become almost asymptomatic within few weeks of treatment. Compare this to other causes of bronchiectasis, where the primary treatment is symptom control and exacerbation prevention rather than hitting at the underlying pathophysiology, which is why the interest in ABPA lies. Moreover, there's a considerable global burden of this disorder with an estimated 5 million cases worldwide. 5 million may seem small, but you compare this to the burden of cystic fibrosis. This number is 4 times the global burden of cystic fibrosis. So there's a huge load of ABPA patients which you are likely to encounter in your clinical practice. Now, this meta-analysis looked at the prevalence of ABPA in asthma. This is a forest plot which shows the assimilation of 47 studies across 6 continents and almost 10,000 asthma patients. Here you can see that there is a high prevalence of ABPA in asthmatic patients visiting tertiary care, with the pooled prevalence being about 11%. Now, I have also shown the prediction intervals which reflect the number which you are likely to actually encounter in your clinical practice. So let's say if you see 100 patients of asthma in your clinical practice, at least 6 to 20 of them are likely to have ABPA. Now, the traditional wisdom is that ABPA complicates the course of patients with severe asthma or treatment-dependent asthma or treatment-refractory asthma. However, the evidence for this notion was weak. So, in a recent study, we showed that the prevalence of ABPA is similar across the severity of asthma. So, it is not affected by the severity of asthma. And this supports the recommendation of the International Society for Human and Animal Mycology, which recommends screening all asthmatic patients for ABPA regardless of the severity or the level of control. So let's begin the first part of our discussion. How do we diagnose ABPA in clinical practice? So these slides show you the sensitivity and specificity of various investigations used for diagnosing ABPA. So sensitivity, as you all know, refers to the ability of a test to diagnose ABPA when the condition is present, while specificity is the ability of the test to rule out ABPA when the condition is absent. So as an example, I have given you 2 scenarios. Look at the specific IgE and look at the serum total IgE. Both have almost similar sensitivity, but look at the specificity. It is varying. So if you use serum total IgE for screening ABPA patients, you're likely to pick up a lot of false positives. And that is why specific IgE is the preferred test for screening asthmatic patients for ABPA. It is the most sensitive investigation in the diagnosis of ABPA, and at a cutoff value of 0.35 kilounit of antibodies per liter, it has a sensitivity, like I showed, approaching nearly 100% and a specificity of about 70%, making it the preferred test for screening asthmatic patients for ABPA. Next, we come to the serum total IgE. So the serum total IgE is a useful test for diagnosing ABPA because a normal value excludes active ABPA as a cause of patients' current symptoms. So 2 cutoffs have been widely used in literature, namely the 500 international units per mil and the 1000 international units per mil. So the ISHAM guideline chose the 500 international unit per mil cutoff because it has a better sensitivity compared to the 1000 international units per mil. Moreover, the diagnosis of ABPA is a multimodal criteria, which I will be discussing shortly. So you will realize that if you choose a more sensitive test upstream, you are unlikely to miss any patient with this disorder. Another important point regarding serum total IgE is that it is the most important biomarker for monitoring treatment response. While specific IgE against Aspergillus fumigatus is a sensitive test for diagnosing ABPA, it is a poor biomarker for monitoring treatment response. And for this purpose, serum total IgE is the preferred biomarker. Next, coming to another important test, which is serum precipitants or IgG against Aspergillus fumigatus. Precipitants, which are detected using the traditional double diffusion method, have a sensitivity of only 27%, meaning that you'll miss 3 out of 4 patients with ABPA. On the other hand, if you perform specific IgG using the fluorescent enzyme immunoassay platform, it has a sensitivity approaching 90%. Indeed, in a recent systematic review and meta-analysis, we showed that one additional positive result could be detected for every 6 tests which are performed with immunoassay compared to the traditional double diffusion method. So specific IgG performed using enzyme immunoassay is preferred over serum precipitants. Next, coming to the imaging aspect of ABPA, imaging plays an important role in diagnosing ABPA. In fact, there are several named signs in patients with ABPA. We'll not be discussing that. The most common chest radiographic finding is finger in glove and fleeting opacities. So you have flitting and fleeting opacities, which are typical of ABPA and few other respiratory illnesses. However, the investigation of choice for diagnosing ABPA, the imaging investigation of choice, is thin section CT chest or the high resolution computed tomography of the chest, where bronchiectasis is the most common abnormality. However, the pathognomonic finding is high attenuation mucus, which is defined as mucus that is visually denser than the paraspinal skeletal muscle. So this is a modeling study where we looked at the various screening approaches to diagnose or to screen ABPA using a decision tree model. So in this study, we found that if you used a serum total Ig based screening approach, it will require significant additional downstream tests compared to the recommended A fumigatus Ig method. So for every 1,000 patients screened, we showed that there will be a saving of at least $1,000 or about 50,000 rupees, which may sound very small amount for 1,000 patients, but given the huge burden of asthma patients in clinical practice, this small initial saving is likely to translate into a huge later savings. In our practice, we have seen that physicians often use eosinophil count for screening asthmatic patients for ABPA, and we clearly showed that if you use this strategy, you're likely to miss a large number of cases, and we estimated that at least 30% of patients of ABPA will be missed if you use a eosinophil count based strategy. Finally, many students ask, why not do CT straight away so you can pick up all patients with ABPA? You could do that. I showed you in the table that the sensitivity is 100%, meaning that it will have few false positives, but please see that you'll require to screen all asthma patients with a CT, and it will, in our study, showed that you will require at least 804 unnecessary screening CTs, and you will still miss 7.5% of the cases because there's an entity called serological ABPA where CT could be normal and the patient can still have allergic bronchopulmonary aspergillosis. Now let's look at the diagnostic criteria for identifying ABPA. So this is the 2024 ISHAM ABPA working group criteria. So ABPA is typically diagnosed in patients who have predisposing conditions, which include asthma, cystic fibrosis, and recently 2 other conditions have been included, which include chronic obstructive pulmonary disease and bronchiectasis. Sometimes ABPA can occur in patients without predisposing conditions. Here, we have employed the term called compatible clinical radiological presentation, which include expectoration of mucus plugs, finger and glove and fleeting opacities on chest radiograph, lung collapse, and others. So if the patient presents with this typical clinical radiological presentation, even if the patient has no underlying predisposing diseases, you can still suspect ABPA and go ahead with other investigations. So in patients with predisposing condition or a compatible clinical radiological presentation, demonstration of two components are essential. The first is sensitization against the culprit fungus, which most commonly is Aspergillus fumigatus. So you have the first essential component, which is specific IgE, which is more than or equal to 0.35 kilounit of antibodies per liter. The second essential component is to demonstrate immunological activation, which is done using serum total IgE, which has to be elevated, and the cutoff, like I said, was 500 international units per milliliter. However, these tests can also be raised in patients with Aspergillus sensitization without allergic bronchopulmonary aspergillosis. Here, the presence of other components, namely specific IgG against Aspergillus fumigatus, presence of peripheral blood eosinophilia, and chest CT findings consistent with ABPA clinches the diagnosis of ABPA in patients with predisposing conditions. So this is the current approach to diagnosing ABPA in practice. Now, the PGIMER classification has also standardized the radiological categorization of ABPA using a standardized approach to identify various ABPA phenotypes. So on imaging, you can classify ABPA into serologic ABPA or ABPA-S, which is ABPA without bronchiectasis. The next category is ABPA with bronchiectasis or ABPA-B, where the patient has radiological presence of bronchiectasis. The next two stages are ABPA with mucus plugging and ABPA with high attenuation mucus. So how do you differentiate between the two? In patients with ABPA-HAM, there will be presence of high attenuation mucus, which is defined as mucus that is visually denser than paraspinal skeletal muscle. These two stages signify that the patients have active inflammation and requires urgent treatment. The last stage is ABPA with chronic pleuropulmonary fibrosis, which is an advanced stage of ABPA where the patient has extensive bronchiectasis, pulmonary fibrosis, presence of fibrocavitary lesions, fungal ball, and pleural thickening. So this is a CT which shows ABPA-S or serological ABPA. Here you can see that the patient has a normal CT chest without the presence of bronchiectasis. And this is ABPA-B or ABPA with bronchiectasis. Here you can see the presence of bronchiectasis. These are dilated bronchi, and dilated bronchi are defined as the inner diameter of the bronchi greater than the outer diameter of the accompanying vessel. Here you can see it is at least 30 or 40 times the size of the vessel. And this also appears like a signet or a ring or a signet ring. So this is known as the signet ring sign. And here you can see bronchiectasis on both the lung fields, more on the left side. This is ABPA with mucus plugging. Here you can see that the patient has dilated bronchi filled with mucus. So this is mucus which is of the same density as this paraspinal skeletal muscle. So this is classified as ABPA with mucus plugging. And this is what I was referring to when I said high attenuation mucus. Here you can see that the mucus here is visually denser than paraspinal skeletal muscle. So you also have an imaging criteria. If the CT Hounsfield unit is more than 70 Hounsfield unit, then it is defined as high attenuation mucus. So this is a pathognomonic finding of ABPA. So if you have a patient with bronchiectasis and if you show high attenuation mucus, you can confidently label that the underlying cause of bronchiectasis is allergic bronchopulmonary aspergillosis. And this is a CT in a patient with advanced ABPA. Here you can see that the pulmonary artery is dilated and there is extensive pulmonary involvement with fibrosis and bronchiectasis. So this is an advanced stage of ABPA. Now, these radiological categories currently have no treatment implications, that you're not going to treat the patient with the ABPA-B very differently from patient of ABPA-HAM. but these categories have prognostic implications. So if you take a patient of ABPA with HAM, he or she is likely to have recurrent exacerbations, and research is ongoing whether these patients should be treated differently than other ABPA patients. So let's see how we take all these individual diagnostic investigations at the patient's bedside. So in patients with predisposing factors or a compatible clinical radiological presentation, you first perform specific IgE. If it is raised more than or equal to 0.35 kilounit of antibodies per liter, then you do a serum total IgE. And if that is also elevated, you do a chest radiograph, a peripheral blood eosinophil count, and specific IgG against Aspergillus fumigatus. If any one of the three is raised, then you do thin section chest CT. And on thin section chest CT, you can classify the patient as having ABPS, ABPB, and other ABPA phenotypes. Suppose the specific IgE is negative, that is, it is below 0.35, and you still think that the clinical or the radiological presentation is compatible with ABPA, then the patient could be having allergic bronchopulmonary mycosis. Like I said, it is an ABPA-like syndrome caused by fungi other than Aspergillus species. Here, the first step is performing sputum cultures or bronchoalveolar lavage fluid cultures and showing the growth of non-Aspergillus species. Once we have identified the particular fungi, we need to demonstrate sensitization, which is done using a skin test. And if that is also positive, then you go in the same fashion as the ABPA algorithm. The only difference here is that you have to do IgG against that particular culprit fungi. And finally, you can diagnose allergic bronchopulmonary mycosis. Fortunately, the occurrence of ABPA is far less common when of ABPM, I'm sorry, is far less common when compared to ABPA. So ABPM is usually seen in form of case reports. I would, in my clinical practice, see one odd patient every year compared to at least 200 new patients of ABPA, which I see every year. So that is how uncommon ABPM is. The International Society for Human and Animal Mycology has also simplified the clinical categorization or clinical classification of ABPA. The clinical classification has been reduced from 8 categories to 6 categories now. Moreover, each category has precise definitions so that it can be used for research purposes across different centers. The definition is, like I said, precise and objective, and each stage has been delineated because it has specific treatment implication. So we have a stage known as treatment response. This is how you monitor treatment response in a patient with ABPA. So here you can see that treatment response is defined as symptomatic improvement by at least 50%. So how do you say 50%? So you ask the patient on a scale from 0 to 100, how much do you think your symptoms have improved? Or for clinical research, you can use a visual analog scale, which is a simple scale which is anchored by 0 mm and 100 mm on the two ends, and you ask the patient to mark his or her improvement. So you have an objective or a semi-objective method of assessing symptomatic improvement along with either a radiological improvement or an immunological improvement. So either major radiological improvement or decrease in serum total Ig by at least 20% after 8 weeks of treatment. So this objective criteria ensures consistent treatment response classification across centers and between different physicians, thereby standardizing treatment response criteria. Similarly, remission is defined as sustained clinical radiological improvement of glucocorticoids. So here the 6-month window delineates remission rather than some temporary improvement, and the presence of the immunological criteria prevents premature classification. So you have stable immunology and a stable clinical presentation and a stable imaging that defines remission rather than some temporary phenomenon. Similarly, exacerbation is diagnosed as sustained clinical worsening or radiological worsening and immunological worsening. So here the key word is sustained. So this sustained feature prevents the classification of temporary worsening because of, say, either asthma exacerbation or bronchitis exacerbation into an ABP exacerbation. So you can prevent a misclassification of ABP exacerbation. And why is it important that you differentiate ABP exacerbation from asthma or bronchitis exacerbation? Because the treatment is different. ABP exacerbations are treated for at least 4 to 6 months, whereas asthma exacerbations are just treated for 7 days, while bronchitis exacerbations are treated for 2 weeks with antibiotics. And we'll come shortly to that. Finally, we have treatment-dependent ABPA and advanced ABPA. Treatment-dependent ABPA is defined as 2 or more consecutive exacerbations of ABPA, each within 3 months of stopping treatments. So here you can see that the requirement of 2 consecutive exacerbations, each within a short span of stopping treatment, defines 2 treatment dependence for which a different therapeutic strategy is required. And finally, we have advanced ABPA, which is defined as extensive bronchiectasis due to ABPA, along with either cor pulmonale or chronic type 2 respiratory failure. So here, the important point here is that if you are able to diagnose ABPA timely and treat it appropriately, advanced ABPA should be a rare occurrence. So moving to the second part of the presentation today, which is treatment of ABPA. Now, the 2 key steps in the pathogenesis of ABPA include the colonization of the tracheobronchial tree by the culprit fungi and a skewed type 2 immune response, which leads to significant airway inflammation, poor asthma control, mucus plugging, which ultimately culminates in the development of bronchiectasis. Now, the management principles are also similar. So it includes the use of anti-inflammatory therapy to control the immunological activity and the use of antifungal agents, primarily triazole antifungals, to attenuate the fungal load in the airways. So previously, a high dose of corticosteroid was used for treating ABPA. So in a randomized controlled trial, we showed that the high dose of prednisolone had no advantage over medium dose of prednisolone, and this led to a paradigm shift in the treatment strategy where the medium dose use of steroid became the norm for treating ABPA. Similarly, itraconazole was not used as a monotherapy in patients with ABPA. Again, in this important randomized trial, our group showed that while prednisolone was more effective than itraconazole in bringing about immediate treatment response, the time to first exacerbation was, however, similar in the 2 groups. More importantly, the occurrence of adverse events or the treatment emergent adverse events were significantly less frequent in patients with itraconazole than in patients receiving prednisolone. So this led to the guideline recommendation of using itraconazole as an alternative to prednisolone in treating ABPA. Another caveat with this study for itraconazole was that we did not perform therapeutic drug monitoring while giving itraconazole in this study. And many of you will know that itraconazole has erratic bioavailability and a therapeutic drug monitoring is mandatory. So if you see in this study where we compared voriconazole versus prednisolone, we found that the treatment response was similar in the 2 groups. This is because voriconazole has a more consistent bioavailability, when compared to itraconazole. And indeed, in this study, we monitored voriconazole levels and we ensured that the patient had the therapeutic levels. Finally, we showed that the combination of prednisolone and itraconazole was not superior to prednisolone alone for treating ABPA. In clinical practice, most patients of ABPA are treated with a combination. The guidelines clearly discourages this because there is no benefit of using a combination therapy and the propensity for side effects is higher with combination therapy when compared to monotherapy. So what is the guideline recommendation for ABPA treatment? While glucocorticoids are the most effective agents in ABPA, antifungal triazole, itraconazole is a first-line alternative. So currently, prednisolone is used at these doses, 0.5 milligrams per kg per day for 4 weeks, followed by 0.25 milligrams per kg per day, 0.125 milligrams per kg per day. Then you taper by 5 milligrams every week to stop treatment at 4 months. If you're using itraconazole, you can use either the conventional capsule of itraconazole or the SUBA preparation, which is supra bioavailable preparation. The dose is 100 milligrams, 2 capsules twice daily. Or if you're using the SUBA preparation, it is 65 milligrams, 2 capsules twice daily. It is imperative that you perform therapeutic drug monitoring at 2 weeks and thereafter at 2 months. The maximum dose of itraconazole is 600 milligrams. Suppose you do a therapeutic drug monitoring at 2 weeks. And if you find that the itraconazole level is subtherapeutic, you can hike up the dose from 400 to 600 milligrams and from 260 milligrams of SUBA preparation to 390 milligrams. Like I mentioned, the combination of prednisolone and itraconazole is not routinely recommended for treating ABPA. It should be used only in patients who have recurrent and frequent exacerbations of ABPA, which is loosely defined as 2 or more exacerbations in the last 1 to 2 years. So the most revolutionary treatment approaches in managing ABPA is the use of inhaled therapeutics. So inhaled therapeutics achieve high concentration in the airway where the disease is actually present with negligible systemic concentrations. So it produces significant effects without producing side effects. So we explored this strategy in a pilot study where we randomized a small group of ABPA patients to receive nebulized amphotericin B versus nebulized budesonide, which was used as a placebo or a placebo arm, you could call it. So we used conventional amphotericin B at a dose of 10 milligrams twice daily, twice a week for 4 months. And we found that the number of patients experiencing ABPA exacerbations were significantly lower in the nebulized amphotericin B group. In the subsequent larger study from the French group, they also showed that the time to first exacerbation was longer in the nebulized amphotericin B group. Unfortunately, in both these studies, the primary outcome was not significant. Hence, ABPA treatment with nebulized amphotericin B has been given a recommendation B rather than recommendation A. Other azoles like voriconazole, posaconazole, and the newer isoconazole are reserved in patients who show little or poor response with itraconazole or encounter adverse effects with the use of itraconazole. Pulse doses of methylprednisolone have been used in the pediatric ABPA literature to prevent the side effects of daily oral steroids. So you give the child pulse doses of methylprednisolone 7.5 to 15 milligrams per kg for 3 consecutive days every month, along with the triazoles to reduce the side effects. In the adult population, we use pulse doses of methylprednisolone only in a very small subset of patients with refractory ABPA exacerbations, where the patients is refractory treatment with oral glucocorticoid because of the development of glucocorticoid resistance. and pulse doses of methylprednisolone can bypass the glucocorticoid resistance. So the in thing nowadays is the monoclonal antibodies or biological therapies, and these have also been tried in ABPA. There's a strong biological basis for the use of these agents in patients with ABPA. So this is a complicated pathogenesis cartoon which shows the various pathways involved in ABPA. Like I said, ABPA is caused by a skewed type 2 immune response. So you can see that once the aspergillus enters the airway, it evades immune defenses and colonizes the airway, releases its antigens, and the host susceptibility triggers a type 2 immune response, which leads to the activation of the IL-4 pathway, the IL-5 pathway, and the upstream pathway. So you have molecules which can block all these individual pathways. And these are the molecules. So you have the upstream mediators. These are the upstream mediators, interleukin 25, interleukin 33, and thymic stromal lymphopoietin. And the ones in green are biological agents which are approved for use in patients with severe asthma. The ones in red, which I have struck out, have failed trials of severe asthma, whereas the ones in red, which I have not struck out, are still undergoing phase 3 randomized trials in patients with severe asthma. So you have omalizumab, which is a monoclonal antibody against IgE, mepolizumab and reslizumab, which is a monoclonal antibody against interleukin 5, benralizumab, which is a monoclonal antibody against interleukin 5 receptor, dupilumab, which is a monoclonal antibody against interleukin 4 receptor alpha, which blocks both IL-4 and IL-13. And then you have tezepelumab, which is a monoclonal antibody against thymic stromal lymphopoietin. Unfortunately, barring a very small randomized trial of just 13 patients with ABPA, the use of biologics in ABPA literature is mainly in the form of case reports or small case studies. And thus the guidelines recommend the use of biological agents only in patients with treatment-dependent ABPA or in patients with ABPA who have contraindication or intolerance to both glucocorticoids and antifungal triazoles. For instance, let's say a patient has liver disease and significant obesity where you can neither use itraconazole or steroid, you can use monoclonal antibodies. Or let's say the patient has concomitant non-tuberculous mycobacterial infection or has recurrent pseudomonal bacterial colonization of the bronchiectatic cavities. Here you cannot use steroids, and these are candidates for the use of biological agents. These are also indicated in patients who have a refractory disease to both corticosteroids and antifungal triazoles. And finally, it's a class 1 indication in patients with uncontrolled asthma, which persists despite the use of oral steroids. So this is the current indication for biological agents in ABPA. They are not to be used in patients with acute ABPA or in patients with ABPA exacerbation. So a word about the treatment protocol. So like I said, a patient who is newly diagnosed with ABPA and meets the ABPA criteria, you can start the patient either on oral prednisolone or oral itraconazole for at least 4 months and not both together. If you are using oral itraconazole, you can give oral prednisolone for the initial 2 weeks if the patient has uncontrolled asthma symptoms. But you should not continue oral prednisolone for 4 months along with itraconazole. So it should be used as a monotherapy. Once you start treatment, the patient will respond to treatment, and then you follow the patient up every 8 to 12 weeks with chest radiograph, spirometry, and serum total IgG. Like I mentioned before, serum total IgG is a preferred biomarker for monitoring treatment response in patients with ABPA. And once the patient is all right after 4 months, then you define that the patient is having remission if the patient is stable for at least 6 months. Now, the natural history of ABPA is characterized by recurrent exacerbations. And if you diagnose ABPA exacerbation, which is diagnosed by either symptomatic or radiological worsening with an increase in IG by at least 50% of the last recorded value, you treat this patient in the same fashion as a newly diagnosed ABPA. So you give the patient again oral prednisolone or oral itraconazole again for 4 months. In patients who have frequent exacerbations and recurrent exacerbations, you can use a combination therapy with both oral prednisolone and itraconazole for 4 months each. And in patients who have treatment dependence, that is, they have recurrent exacerbations on stopping treatment on at least 2 occasions, you can use any of these agents, which include oral itraconazole, a biological agent, nebulized amphotericin B, and in those who cannot afford any of the treatments or who are not willing for any of the treatment, you can use low-dose prednisolone, which we define as prednisolone dose less than or equal to 7.5 milligrams every day. So this is how I said treatment monitoring. Needless to mention that you need to monitor these patients for adverse effects and drug interactions. Another important point is that if you're using oral itraconazole, like I mentioned before, you need to perform therapeutic drug monitoring at 2 weeks and 2 months. So the course of ABPA, like I mentioned, is punctuated by recurrent exacerbations, which can either be asthma exacerbation or ABPA exacerbation or bronchiectasis exacerbation. So how do we differentiate between the three? The most frequent is asthma exacerbation. However, the most important is ABPA exacerbation, which is defined as clinical or radiological worsening and an increase in serum total IG by at least 50% from the last recorded value. Asthma exacerbation is diagnosed when the patient has clinical worsening without immunological worsening and imaging stability. So if the patient has only clinical worsening without immunological or radiological worsening, we classify this patient as having asthma exacerbation. And finally, you have bronchiectasis exacerbation or infective exacerbation of bronchiectasis, which is defined as clinical worsening and microbiological evidence of infection, but with immunological stability. So this is how you differentiate between the 3 exacerbations. Like I mentioned before, it is important that we differentiate because a bronchiectasis exacerbation is treated with a 2-week course of oral antibiotics without the use of prednisolone, whereas an asthma exacerbation is treated with a 7-day course of oral steroid with or without antibiotics, whereas an ABPA exacerbation is treated with at least 4 months of oral prednisolone or oral itraconazole. Finally, a word about future therapies or where the treatment protocol is headed. So we have recently completed this randomized controlled trial where we have compared deflazacort versus prednisolone in acute stage ABPA. Deflazacort is a novel oral glucocorticoid which is believed to have lesser metabolic side effects when compared to the traditional prednisolone. So in this study, our primary outcome is weight gain in patients ABPA. So we have completed the last patient follow-up, and possibly in the next 6 months, we'll be able to tell you which is a better choice of corticosteroid in patients with acute stage ABPA. The revolutionary thing in ABPA is the use of inhaled antifungals, and you have several drugs in the pipeline. The UK group is investigating nebulized opalconazole, which is a novel inhaled antifungal triazole. Another group is looking at the dry powder inhaler preparation of voriconazole. In India, Cipla Pharmaceuticals has completed the phase 2 study of inhaled itraconazole in patients with ABPA, and the results are going to be presented in the upcoming European Respiratory Society meeting. recently, a phase 2 study of dupilumab has also been completed in ABPA, which was presented as an abstract form in the American Thoracic Society meeting, and the preliminary results look encouraging. However, the abstract is silent on what type of ABPA patients were included in the study, whether they were acute ABPA or treatment-dependent ABPA. We don't know yet, and the final publication will tell us what is the positioning of dupilumab in patients with ABPA. Anyway, this is a phase 2 study, and the molecule will move now into a phase 3 trial. And if it is efficacious in a phase 3 trial, only then we can use it routinely in clinical practice. So, in summary, you need to maintain a high index of suspicion for ABPA in patients with asthma, regardless of the severity or the level of control. You need to screen all patients of asthma in tertiary care with a specific IgE against Aspergillus fumigatus, which has almost 100% sensitivity at a cutoff of 0.35 kilunit of antibodies per liter. Glucocorticoids or triazole antifungals, specifically itraconazole, are first-line treatments for acute stages of ABPA, both the newly diagnosed ABPA and the acute exacerbation of ABPA. And I strongly believe that the 2024 ISHAM guidelines will help bring uniformity in diagnosis and simplify the management of ABPA patients in both clinical care and research. Thank you once again for your kind attention, and I'll be happy to take up any questions. Thank you.
Thank you very much, sir, for the wonderful lecture. And we all have seen that in ABPA, like if we talk about ABPA, so you have a unique leadership among the various scientists or clinicians in the world. So thank you for the insights. I request all the participants to write their queries in the chat box, or they can raise their hand. We will unmute them and then they can ask it. So, sir, there are already questions we do have in our chat box. So, how effective? I think these are answered, but I'll read out these questions for you, sir. How effective is omalizumab in steroid-dependent ABPA or as a steroid-sparing agent in elderly, diabetic, or hypertensive patient?
So, like I mentioned before, there are no large randomized controlled trials of omalizumab in ABPA. We have a single randomized crossover trial of 13 patients where they used omalizumab in ABPA. It was fairly effective. So, it showed that the basophil sensitivity to Aspergillus fumigatus decreased, and patients receiving omalizumab had lower exacerbations during the treatment phase. How effective it is, it's not very clear because we don't have a large randomized controlled trial. Please remember that ABPA is different from other causes of severe asthma. Here, the inciting agent, namely the Aspergillus fumigatus, is actively growing in the airways. So unlike other causes of asthma where the inciting agent comes and goes and is not permanent, here the agent is permanently residing in the airways. Plus, if you use, let's say, omalizumab or mepolizumab or benralizumab, you are targeting only one part of the immune cycle. So it is possible that various immunological pathways are active in a particular patient. And if you give omalizumab, you're not targeting the interleukin-5 pathway and the patient may continue to have symptoms. So that is why biological agents are not used for treating acute phases of ABPA. Once you bring about response, you can continue to maintain the response with the use of biological agents.
Right, sir. Right.
And like I said, in patients who have contraindications to the use of corticosteroids, like you said, elderly diabetic patient or hypertensive patient, certainly once you bring about response with itraconazole, and if the patient is not fit for any of the other therapies, you can continue, you can try the option of omalizumab or other biological agent.
Right, sir. So these biological agents are good, pretty good, where corticosteroids are contraindicated. Right, sir. Thank you. So as you told that steroids are particularly very effective in like treating ABPA. So at times, steroids, they are also known for the resistance over a period of time. So the next query is regarding the same. So they asked how effective and safe is dairy filing to break steroid resistance, and what about the risk or benefit ratio of the same? So
I'm not aware of any study specifically looking at the role of periphyllin uh, counteracting steroid resistance in ABPA. Fortunately, we have itraconazole. So if you believe that the patient has steroid resistance, you can stop steroids, start the patient on itraconazole, and by that time, the steroid resistance will go away, because the pathophysiology of steroid resistance is continual exposure to steroids, which downregulates the glucocorticoid response elements, and that leads to glucocorticoid resistance. So, fortunately, we have another effective therapy, which is antifungal triazole. So you can stop steroid, start oral itraconazole, and that is how you can counteract glucocorticoid resistance.
thank you, sir. So it's an insight for the participants that like no literature found that no literature I think exists that terifilin can break that resistance, right, sir? Okay. So next question is sir from YouTube. Like since we all know, sir, that India is like a rich country in if we consider the cases of pulmonary tuberculosis. So we have lot of cases of tuberculosis, and often the cases of ABPA, they are misdiagnosed, or ABPM, they are misdiagnosed and often confused with tuberculosis, since considering its most prevalent disorder, even the patients of ABPM or ABPA, they are put on ATT. So okay, sir. So, like mainly it does happen in the remote areas. So another question is from one of our participant on YouTube, that how can technologies such as telemedicine or AI-driven diagnostics they be leveraged to improve the diagnosis and management of ABPA in remote or undeserved areas of India?
Correct. It's a very important question, given the the burst of artificial intelligence technologies.
So,
And certainly you can leverage the use of artificial intelligence to identify a pattern, the diagnostic, the chest imaging pattern of EVPA versus pulmonary tuberculosis. Having said that, the differentiation of EVPA from pulmonary tuberculosis is very simple. So I personally believe that rather than leveraging AI to do this, if we have small workshops like this, which the NAMS has undertaken, we can create a large group of doctors who can then use their knowledge to diagnose. For instance, what happens, how is ABP misdiagnosed as pulmonary tuberculosis? Because the emphasis is primarily on the imaging. So you see the imaging, if there is some right upper lobe opacity, the physician thinks that, okay, the upper lobe opacity in India means tuberculosis. So they don't even do a microbiological confirmation. So currently we have a very good microbiological confirmation tool, which is Gene Expert. So Expert MTBF assay. So if we are able to align that protocol in our day-to-day practice, we are unlikely to misdiagnose ABPA as pulmonary tuberculosis. In fact, in our experience, almost 1/3 of the patients of ABPA have inappropriately received anti-tuberculosis therapy in the past. It's a huge number.
that's a huge number, right, sir. So, sir, are there any other tests other than Gene Expert test? Because Gene Expert availability of this test in remote areas is again like big question. So,
Uh, if you say in the most remote area, what can we do? So currently, a point of care test has been marketed.
okay, sir.
So, but unfortunately, it has not been widely what you call tested in practice. So, if you have that point of care test, so if you have, that's a simple test. So you do a prick in the finger prick, and you take 1 drop of blood, and if that it's a lateral flow assay. So it's like the simple kit test for dengue or malaria. So rapid diagnostic test. So if you have 2 lines, that indicates the presence of Ig antibodies against Aspergillus fumigatus. So hopefully in the next year or so, once that kit comes to India, and we are able to perform the initial testing that can be used in the most remote areas because it will not require any lab support, and you can diagnose at least ABPA. Now, how we get the gene expert in the periphery, I think the National Tuberculosis Elimination Program already has got the nucleic acid amplification assays which run on a battery operated protocol into the periphery. So I think the combination of the two will certainly help us in reducing misdiagnosis.
Right, sir. So definitely this antibody detection test, like this ELISA kit, if it is available, yeah, this would be like wonderful and mainly in
We
remote.
already have a point of care assay for IgG
Right.
against populous fumigators. So if you have also for IgE, it will make the diagnosis very easy. And if the patients are positive, then a specific patient then can be referred to a secondary levels of healthcare or a tertiary levels of healthcare.
Facility. Right, sir. Right, sir. Thank you, sir. I again request the participants, they can just raise their hand. If they have any doubt, we'll unmute them and they can ask the question verbally if they are unable to type it.
Plus, I have also given my email.
Sir.
So if you have any questions, and if you don't wish to ask, you can also email them to me, and I will try my best to respond as quickly as possible.
Right, sir. Thank you so much, sir. Thank you so much. So, again, I would say that it was eye opener, I would say, on the topic of ABPA. Attending this lecture was uh, a good thing, and from on the behalf of National Academy of Medical Sciences, sir, I again thank you from bottom of our heart. So we have all the attendees, like we have postgraduate residents. We also have medical officers from remote areas. So one of the medical officer, they asked this question. Okay, so sir, this medical CME program, this was started by Professor Shiv K. Sarin, sir. He was the immediate past president of National Academy of Medical Sciences, and the tradition was continued by Digambar Behra, sir. So Professor Behra is from PGIMER Chandigarh, you know him, sir. And Professor Umesh Kapil, sir, he is the secretary of NAMS, and he has been continuing with Professor Ajay Kumar Sood, sir. They both couldn't attend today. I personally spoke to them. So due to ill health and other engagements, they couldn't attend it. So
It's a very
sir,
excellent platform for postgraduate teaching, and
Sir.
I'm very delighted to participate today.
sir, thank you, sir. And I also thank you. I also thank Mr. Raviji and Mr. Shivam for the technical support. Like they have been a continuous support, sir, for this medical CME program, and success of this CME like has been dependent on them since beginning. So I think with these words, I would like to, yeah, we can conclude this, sir.
Thank you.
So thank you for your valuable time and valuable input, sir.
Thank
And
you.
thank you very much, sir. Thank you.
Can I leave?
Sir, thank you, sir. Yes, sir. Sure, sir.